Thank you very much, OR UK, for the invitation, especially to Ruth, who really has a finger on the pulse of orthopedic courses in the UK. I would like to also thank Firas Arnott and all the organizers at the FRCS Mentor Group, who are exceptional in that they've been doing this online teaching and webinars for over 2 years, which is way before anyone before this COVID crisis. Thank them for the invitation. The plan of my talk is, let's do it in the manner of the common FRCS questions we will have, some use of terminology, and then talk a bit about constraint, stems, and augments, and just using the words correctly. This talk is important that it's not for me, but these are phrases which you all must verbalize and to help you get a 7 or 8 on the table. And it doesn't matter if we have to go a little slow, but I'll just repeat myself a few times. So the common FRCS auth questions. So imagine that you are on the basic science viva, and I ask you as the examiner, or the examiner asks you that, have you been involved with knee replacements? And your answer will be yes. And then I'll ask that, what do these two lines represent? So what does this line represent? And what does this line represent? So the answer would be, yes, I do know, and I've been involved with knee replacements. These two lines, this represents the mechanical axis, and this represents the anatomic axis, which goes down the shaft to the femur. Then carry on and tell the examiner why these two lines are important is that my goal of knee replacement surgery is to place my femoral component at 90 degrees to my mechanical axis. However, in real life, as a surgeon, I would be using the intramedullary rod for my instrumentation, which goes up the anatomical axis. Hence, I do know I'll have to dial in the difference, and that difference is between 5 or 7 degrees, and that's called the valgus cut angle. So I repeat again, this question would have been about your verbalization of saying a valgus cut angle, and you really know why it's 5 to 7 degrees, and also what is your goal of your knee replacement. Okay, so that's one concept, or that's one question out of the way. I'll go on to the second question. Imagine you're on your basic science viva and you're shown this, and please understand this is your setting question. There are no marks to you if you get what this is or not, but this is a femoral sizing jig. It can be of any system, but the question I'll ask you is that any modern knee system will have a hole here saying right lateral, and then it'll have a hole here saying right medial. They're not at the same level. They're a little, one is above here and one is below. And this is to give a degree of rotation. And I'll ask you, why, what rotation is it and why is it there? And your answer would be, yes, there's a certain degree of rotation, which is an external rotation, and it's about 3 degrees. And the answer would be, why would it be 3 degrees? Most often, the answer given to me is that you need external rotation for patellar tracking. Yes, you might need it, but the primarily basic science reason for why modern knee systems will have some degree of external rotation built in is that you tell the examiner that my goal of knee replacement surgery is to balance my flexion extension gaps, and everybody will agree on that. Then say, when I cut my, then say with the normal virgin tibia, non-replaced, will have 3 degrees of varus. However, when I do my knee replacement on the tibial side, and I'm staying on the tibial side, not the femoral side, when I do my knee replacement on the tibial side, I cut my tibia at 90 degrees to the long axis, and therefore, to balance my flexion gap, I have to dial in that amount of external rotation on the femoral side, and that's the reason for that. So I'll just recap for you. So you tell the examiner that the normal virgin tibia is in 3 degrees of varus. Then tell the examiner that my goal is to balance my flexion and extension gaps when I do my knee replacement. I cut my tibia at 90 degrees to the long axis of the tibia, and hence to balance my flexion gap, I need that degree, that difference, that is the 3 degrees. Remember, there was 3 degrees of varus. I need to dial that in, and I dial that in on the femoral side. Then say, I do know that optimal or correct rotation external rotation is important for patella tracking and other kinematics. And hence I use on the femoral side, I do know there are a number of axes, and say the common one used is the posterior condylar axis. That's a commoner one. However, in some situations, you can say, especially in the valgus knee where there's lateral femoral condylar loss, that may not be the correct axis to use because I'll get that axis wrong. Then there says another axis called the epicondylar axis, which in real life as a knee surgeon is difficult to get. And hence I can use my White-sized line or the anterior posterior axis, which is a line from the deepest part, from the apex of the notch, that's the apex of the notch, to the deepest part of the groove. And that's 90 degrees to that is my axis. Okay, so that's where we are on the femoral side. So that one concept is over, and let's move on to the patellar side. So this is a common question I'm going to ask you on the basic science Viva, that you've joined me as my colleague, knee surgeon, and will you be resurfacing your patella or not? The first thing to say is that there are many questions in orthopedics which will be asked where you do know, as you are becoming a consultant, that there are controversies or there's no true answer. And the best way to verbalize that would be to say 3 types of studies. The first would be long-term implant survival studies. You can say at the moment, there are no true long-term implant survival studies which say it or benefit resurfacing or not. You can say there are no true patient-reported outcome measures which say, yes, we should resurface over the other. But then say, however, at the basic science level, I do know that the patella is important for quadriceps function. That's the line you would say. And then say within that, the important issue for quadriceps function would be the height of the patella. And hence say, I would like to draw you the diagrams around the knee, and therefore say that I would like to draw my patella, my quadriceps tendon, my patella tendon, and then say, I like to resurface the patella because I want to recreate the patella height, because I do know by recreating patella height optimizes quadriceps function. Or you can say, if you want to be a non-resurfacer, but justify your answer, you can say, I do know that recreating patella height is important at the basic science level for quadriceps function, but there have been no patient-reported outcome studies showing real superiority over resurfacing or not, and hence I do not resurface. But the basic premise is that you do know what the patella was there for, what is the reason of the patella. You do know that you're going to be able to talk about the importance of height of the patella for quadriceps function. You do know that you'll be able to draw a patella with the quadriceps tendon proximally and the patella tendon distally. You'll have another arrow showing the joint reaction force, and you'll be able to draw the diagram of the forces around the knee. So I hope this small part of patellar resurfacing has covered a lot of what you potentially could be asked, or at least your concepts will be clear. The next big heading is, would you join me as a consultant? And now, would you use a cemented or uncemented knee? Going back to our premise of long-term survival studies and patient-reported outcome measures, in this we can clearly say, at least at the present time, the evidence is strongly in favor of cemented knees. Of course, there are surgeons now using uncemented knees with good follow-up, but as a basis, most surgeons at the moment, the evidence would be to use cemented implants. So say, yes, I will be using a cemented total knee replacement on the femoral side and the tibial side. And with cement would use, please understand, we'll be using what is called a standard viscosity. So in the world, we have 2 types of cements, there's standard viscosity and low viscosity. The low viscosity we don't use in knees, we use when you do things like exit a hip. So say I will use a standard viscosity cement, and that's the 3rd section on cementing done. And this nicely leads onto which knee we'll use as why, which I understand is quite an important question which phases candidates as to what you should answer for this. So my message to you is, the first thing to say is that just say the implant you'll use. And within that, say I will use a posterior stabilized total knee replacement and give the brand name, whichever you want to use. Then say, it'll be cemented with patellar resurfacing. Now, when you give an answer like this, which covers this, at least you're starting with a mature answer. So, or if you don't want to use a PS knee, you can say I use a posterior retaining total knee replacement, which is cemented, it does Zimmer knee, and I don't resurface the patella. But you can't just stop there. You have to justify why you use things. So let's move on, and I'll give you a few points into why it's important. So just say I need a knee system which can be used for all anatomical variants. I need a versatile system which immediately I can jump up if I want to use a stem or an augment for a complex knee. Then say I need a knee system which incorporates my philosophy of balancing. We don't have time to talk about different balancing techniques, but you should know which balancing technique you use. And so you need a knee system which incorporates that. Then say, this is where we come in, where most people jump onto NGR and things. So yes, say I need a knee system with a good proven track record. You can use your NGR data quotation here. You can say I need a high ODEP rating. And more importantly, I'll just give you a tip that for knees, hip, anything, just have one good paper for a long-term survival, which you know about. And that brings us on to my next section of the talk, is let's just make sure that terminology of phrases used are correct. So let's first start with constraint, then move on to stems, and then use on to what is called a sleeve and an augment. And these four words should not be used interconnected. They are all different entities. So what is constraint? Constraint, you can say, is the inherent stability which an implant provides without the need of a soft tissue envelope or structures. Okay, so the inherent stability that implant gives is called constraint. And then we move on to how do we go up in the degrees of constraint. So from a normal knee, which we do, we go higher constraint. And the first higher constraint we come to, and please use this word correctly, is try not to use a brand name. Say that I would like to use a partial varus valgus constrained knee. And the next level up would be called a fully constrained knee, which we all know is a hinge. And nowadays, we don't use a hinge knee, we use a rotating hinge knee. So the next level up from your normal knee replacement for constraint would be a partial valgus varus constrained knees. And then say the next level up would be a fully constrained knee, which is a rotating hinge. Very important now. When I ask a question that, look, this is a significant deformity of this knee, do you think you need constraint? And everybody says yes. You can't judge that. The reason for constraint is when you have put all the deformed bone back to where it was, and then when you're checking the integrity of your collaterals, then if there's a laxity issue, that's the time you use constraint. So it's not necessarily only for severe deformity due to bone loss. Once we recreate the bone loss, and then if we check for laxity, and then if we do have a laxity issue, then of course we use the higher degree of constraint. How do we get this higher constraint? So example, on your table, you may be shown an implant like this with a high box. So say you get the higher constraint because of a higher box, a higher spine, and with a reinforcement pin. So when we do cut our normal knee replacement, this is the slot we use. If we're using a higher constraint, it'll be much deeper, like it's shown here, and the corresponding tibial insert spine will be longer, and you'll have a reinforcement pin. Then we go on to the higher level. This is your fully constrained hinge knee. Here we use it when there's no doubt there's a loss of collaterals. And I've just given you two examples of that. The next section is, when do we use a tibial stem? The answer to that is the minute you've gone up in your degree of constraint, you need a stemmed implant. Okay, that's the first answer you'll give. Then say, whenever I use any type of augment or a sleeve, which I'll come to what they are, on my tibia or my femur, I will use a stem. The next indication for a stem is when you have a defect on the tibia or in the femur, but more likely in the tibia, which is not so large that you're going to use an augment or some sleeve or a cone, then you will use just a stem. So when the bone defect is not large enough. Let's example, you prepare your bone, it's very not good bone quality, then you'll say, look, let me put in a stem. And I say that if you have a previous tibial plateau fracture, when I come to tackle them, even if it's 1 year down the line, I tend to use a stem. So this is when we use a stem, and use the word correctly. We are only talking about a stem, which is the long part which goes into the tibial tray. So then I'm going to ask you the basic science level. Can you just tell me why a stem helps? So the answer would be that by adding a stem onto my tibial tray or my femoral implant, it increases the surface area of the construct. And by increasing the surface area of the construct, it dissipates the force away from the implant bone interface or the implant cement interface, and hence it prevents loosening. So I'll just repeat that for all, that because we use a stem is to increase the surface area of the entire construct. And by increasing the surface area of the entire construct, we are dissipating the force away from the bone implant or the implant cement interface, and therefore prevents loosening. We end with, when do we use augments or sleeves? We say if there's bone loss, and look at this x-ray, there's no doubt there's bone loss here. The first thing, like I said, we want to recreate this bone loss. Once I recreate the bone loss, then I ask myself if there's a problem of ligaments or laxity. If there isn't, then I don't need a constraint, but for that bone loss, remember, I've used a metaficial sleeve. That's a sleeve. Augment is similar, but I've stopped using augments. But augment is anything which attaches. You know, it's like a step which comes wherever your defect is, and that's called an augment. So I hope I've run through the words, the stem, why we use it. I've run through the phrase of constraint, when we use that. I've run through when we use augments and when we use sleeves, and augments and sleeves are interchangeable. And that's when we use it there. Thank you.